Okay, I think we'll be ready to start, and great to see so many people still with us for the second half of the event. I mean, we've got a tough act to follow building on what's gone before, but I'm pretty confident with our next set of speakers we'll be able to achieve that. So welcome back, everybody. So this next session is going to focus on 3 projects taking place in the Midlands, and we're going to hear from a range of colleagues who are involved in deployment of remote monitoring solutions in care homes, where we'll be joined by Dr. Qureshi and Roma Holland. We've got Alison Shaw in Leicester, who will be talking about remote monitoring to support long-term conditions, and a project looking at deployment of ECG and mental health services. We'll be hearing from Harinder Kaur and Lexi Island. So each speaker is just going to take it in turn for 10 minutes, and then we will come back for a panel discussion with everybody at the end. So we'll be picking up comments and queries through the chat, so please continue to use that, and we'll be taking notes to sort of ask our panelists questions at the end. So I think is our first speaker on. We've got Dr. Qureshi and Roma. Are you with us both? Yeah. Excellent.
Yeah, we're here.
If you're not speaking, would you mind just putting your cameras off just so we can see both of your lovely faces? Excellent.
Okay, thank you. And am I going to do my own slides then?
We'll advance them for you if you would just want to say next slide.
Okay, right, next slide then, please. Thank you. Dr. Qureshi, our GP programme lead, Sue Jacobs, our project manager, and Ian Flowerday from Dockerbow, and I myself, Roma Holland, would like to present to you our learnings from the implementation of our Dockerbow system. In this slide, and the slides will be shared afterwards, so I'm going to go through them at pace. In this slide, you will see the programme leadership team identified the frameworks which were the backdrop of our programme and also helped us identify what our deliverables were going to be. As you'll see here, the purpose was to deliver on the Enhanced Care Home DES, also to deliver on the Investment and the Impact Fund, the Ageing Well framework. Our biggest goal of all was to make sure that we'd got system integration. So our clinical system for GPs was EMIS. So we needed to ensure that in actual fact, the Dockerbow solution for our remote monitoring was going to integrate into that system. Next slide, please. The 4 pillars of Ageing Well framework really helped us to identify which system services would have the greatest benefits from using this technology, provided the direction of travel, and it also helped us determine what the outcomes and the key performance indicators would be for the delivery of this programme. Next slide. The governance structure provided the system-wide assurances, and it also allowed us to identify the key stakeholders that were also going to benefit from this programme. The appointment of a GP as a system programme leader was a game changer for us because it allowed the PCNCDs the knowledge that somebody who understood their work pressures, understood what benefits that they were looking for their patient, really they trusted this person who was going to lead on the programme. Likewise, we appointed in as our senior responsible officer someone from the local authorities because that helped the programme influence the contracts for the programme itself. Next slide. We established as part of the governance task and finish groups by work stream, but also that allowed us to develop those task and finish groups at place and on a PCM basis. This allowed the ownership and the culture change to take place actually at the work face. Next slide. Dockerbow offered us animation tools which really helped us provide the care homes and their relatives with actually what developments the Dockerbow remote monitoring ward round could provide to their residents in the care homes itself. It also enabled us to integrate the remote monitoring into our GP overall strategy And it also allowed us to articulate in our data privacy impact assessments exactly where the data flow was going. So we had a full governance overview of the programme. Next slide. The other thing we greatly learned on was by having a strategy plan for the implementation allowed us to really plan and do the trajectory on where the kit was going to go. It also helped us engage with those PCNs so that actually they could see where the deliverable was taking place across their areas. We've now got the remaining 21-22 plan there at the bottom of that slide. And then later on, I'll show you where we're going into 22-23. Next slide. The care escalation flowchart was designed and will be used across the system. We found that using a standard approach will help us deliver against this programme. This flowchart is also supported by a triage algorithm, which is used in our clinical hubs. Some of you will call those the ICC or the ISPAR. And what we've now done is use them to monitor the alerts as they're coming in, as opposed to the GP practice. I will show you the benefit shortly as to what we gained by using that method and approach. Next slide. Again, we've used animation to be able to articulate to the care home staff as part of the engagement where the benefits would come for them, be it proactive or reactive care. We've also used this in our learning disabilities, and as you can imagine, using something that's pictorial has been a great benefit to the residents so that they themselves can understand why they're participating or being asked to participate on this programme. Next slide, please. An evaluation framework has enabled us to communicate the benefits to the boards and to the primary care commissioning committees. Using the framework has helped us now start to look at where we're going in 23-24. So we're using these benefits to go into the service specifications for the contracts, and that's been a great advantage. Next slide. As a provider of this remote virtual ward round service for the care home, we have identified the system benefits. Again, this has helped us be able to communicate back to the key stakeholders where we are seeing the change within the pathway of the patient, and also it's helping us now to map out where the changes in the system will take place so that we can move the workforce resource or funding to be able to support this programme as we go from project to business as usual. That has been a great help, and that will really help us going forward be able to start looking at the commissioning elements of where the funding needs to be moved. Next slide, please. This Docabo informatic has been a great help, not only in our learning disabilities and care homes, but we're now going to use this for our PPG engagement and our Health Watch Board engagement. Our evaluations have clearly indicated that actually we need to start now getting the patient voice. It's the right time for us to now start participating with those patient voice committees so that actually we take the communities with us on this journey, and we actually do a holistic culture change across the whole system. We've also realised that as a programme, we need dedicated comms within the programme to actually make sure that we are using all of the different approaches of communication. So we are getting key messages out there and people are seeing the benefits that this service is now providing. Next slide. To date, these achievements are only interim achievements with the care homes that we've currently got on, but already you can see that 88% of the notification alerts that go through to the clinical hub are responded within 2 hours, therefore achieving the Ageing Well target. Further digging into what's happened to the other 12% has indicated that actually we need dedicated phones, mobile phones, to go into the care homes. So when the alerts go off, we have a direct emergency line, a bit like the red bat phone, for us to contact the care home so that we can actually take actions. 100% of the GPs, the PCNCDs, have all stated that they believe using the remote monitoring service is something that they are confident is delivering improved outcomes to their patients. Next slide. Our next steps for 22-23 are to scale up the rollout. Our experience has now told us that we can compress that rollout from 12 weeks to 8 weeks, so we'll get bigger traction. We need to develop a training team, and we've already started to appoint in 12 link workers who will be there to support the care home staff and the staff in the learning disabilities. Also, like the other speakers that you've heard today, we're also doing a hospital at home, and we're doing long-term conditions. So these support workers will help do the training and develop our patients to be able to manage the technology. The other part of this is we've also worked now with the University of Warwick, and we're taking on research fellows, and they're taking research studies using this remote monitoring. So we're looking at getting some publication into it as well. And our GP IT fellows are very interested and also doing their research projects on this programme. Now, I'd like to hand over to Lucy, who will put our video on here. And again, Docobo were very encouraging for us to use videos to get messages across, very similar to what we've heard from Barry this morning, because actually that is the greatest confidence builder that you're going in the right direction. So Lucy, could I ask you to put on our champion Mary, who I'd just like to say is 94 years of age, and she is demonstrating that actually even at 94 you can use technology, and she got all the benefits that Barry described earlier on.
I must say, the service I'm getting is absolutely brilliant. Doc at home is an absolutely amazing idea, and it's made me feel so much more safe is the word, I think. And anyone I've had involved with them, the nurses and everything, they are the most lovely people. So don't anyone ever be worried about not using them. It's the best thing that's ever happened.
Thank you so much both for that fantastic presentation. We're going to be joined now by Alison Shaw. Alison, are you with us? Are you able to pop on the screen?
Yes, hello.
Thank you, Alison. Lovely. You're going to take us through now your project in Leicestershire Partnership. Thank you.
Yeah, so good morning. My name's Alison Shaw, and I'm the lead for the respiratory team in Leicester, Leicestershire and Rutland. We have the next slide, please. So a little bit about us. We're a community-based team of approximately 15 respiratory specialist nurses and physiotherapists. We're a consultant-led integrated team supporting patients remotely across Leicester. We're closely linked to the Acute Trust and have developed a really good relationship with the hospital team, and we work together and we hold weekly MDTs. When we initially discuss with patients about digital monitoring, we ensure that they understand that technology isn't a replacement for face-to-face patient contact, but it simply supports patient care delivery in a new way. During the pandemic, we actually found that a lot of patients preferred to be monitored this way rather than having the face-to-face contact, bearing in mind the vulnerability of our patient group. The clinician will agree the frequency for inputting the data with the patient, and this can be 2 to 3 times a week, depending on how stable that patient is. And during an exacerbation, for example, they can be monitored daily, and then this can be reduced back down again following the exacerbation, back down to 2 or 3 times a week. Each patient has their own individualised care plans, which is fundamental, and their vital signs, the parameters can be adjusted and tailored, for each patient's needs. We support our patients to use technology and ensure that all patients are considered for this monitoring. It's available for all patients who wish to use it, and we've never made any assumptions as to which patients can or can't use it. Some patients in their 50s struggle to use technology, and then we have some patients in their 80s who you might expect would be less familiar with using technology and devices, but they tend to manage really, really well. So we're an inclusive service, not an exclusive service. One patient that we had, he'd never used a smartphone or a tablet. It was an elderly patient, and they were shown how to use the tablet and began inputting the digital monitoring data. And they got on so well with it that they decided to buy their own tablet. And then they were able to keep in contact with family during the lockdown via WhatsApp. So it just, it's fantastic. It just goes to show you that you're never too old to learn to use this technology. We can show family and friends how to use the technology to assist patients as well if it's needed. For example, if there's a language barrier or dexterity issues or sight impairment. And we can visit patients as well, set them up at home with the technology, and they also have access to the digital company for any IT support. There's information for the patients there's information modules for education around exacerbation management and breathlessness, and patients are shown these and they have access to these at any time that they want to. They can contact their clinicians by sending a message on the device or calling in. And there's also a video function, which is ideal for checking patients' inhaler technique, for example. The clinicians can also message the patient as well, for example, asking them to renew their rescue medications for Christmas holidays, bank holidays. And also, if they don't need to input over a bank holiday period, they can let the patients know that quite easily. A recent study showed that in Leicester that digital monitoring reduced unscheduled COPD admissions by 67%, and Leicester City CCG amassed a cost saving of £117,500 in 12 months. 96% of patients who have used the digital monitoring reported that they felt confident, knowledgeable and motivated to manage their condition. Feedback generally from patients is so positive. They say that they find the regular monitoring really helps them understand what's normal for them, and when things are not quite right, they have that insight into that. Clinicians will contact patients if they alert on the monitoring, but we sometimes find that patients who have been on it for a while have already started their treatment. They will have increased their salbutamol inhaler use, or they've already started their rescue medication, and that's what we want. We want them to be to have that self management awareness and know their condition and know when to start their treatment, and that's fantastic. They say that they find the regular monitoring supportive and reassuring, knowing that a specialist clinician is keeping an eye on them, basically. Some patients prefer this way of monitoring rather than home visits. It's quick, it's more convenient for some patients to input that data rather than waiting for a home visit or having to attend a clinic appointment. Also, we are able to double check information. If a patient inputs oxygen saturations that are reduced for them, we can then just ring them and ask them to recheck them for us. One patient that we have was referred to us by a GP following frequent exacerbations and short stays in hospital, always requesting rescue antibiotics and steroids. So they were referred to us. We then talked to them about taking part in the digital monitoring, and through that regular inputting and understanding of how to manage their condition, they were able to identify what a true exacerbation was, which did require antibiotics and or steroids, and what was just an off day, which didn't require those. This was then able to the patient to reduce the number of rescue packs that they were ordering, and because their clinician was monitoring them and contacting them if things alerted, it gave that patient that reassurance and support. The patient then went on to sing in their choir, their local choir, on a regular basis, and it was fantastic, and they felt that they got their life back. Finally, other digital service that we have in Leicester are the COVID virtual ward, where we monitor patients closely daily for 14 days. We've also got a digital pulmonary rehab programme for patients who perhaps don't want to attend classes at the minute or can't attend classes but still wish to take part in the programme. And also being developed at the moment is a digital pathway for managing COPD patients who have been immediately discharged from hospital, and this is a supported discharge pathway. Thank you.
Thanks so much, Alison. We'll look forward to speaking with you again after this next presentation. And then lastly, we are joined by Harinder Kaur and Lexi Ireland, who are going to take us through the ECG project.
Hello everyone, I'm Harinder Kaur and I'll let Lexi introduce herself. So my key role has been as a senior programme consultant working over the Midlands region is to deploy tech-enabled solutions. So one of them's been the ECGs and the other tech has been around physical health checks for SMI patients. Lexi, do you want to introduce yourself?
Hi, good morning. I'm Lexi Ireland. I'm Senior Transformation Manager for Mental Health at Coventry and Warwickshire CCG. And as Harinder mentioned, this has been part of our physical health check for SMI patients project.
Thank you. OK, so overall, what happened was there was a wide distribution of the Cardia 6-led ECG machines. So they were received by all of the Midlands ICSs. And what we're finding at the moment is it's still quite early days in terms of piloting and deploying the technology. It's more or less being deployed across mental health sites, which is enabling the healthcare trusts to kind of use the 6-led in line with the 12 lead ones, which were already mostly kind of over the Midlands already deployed. So with the 6-led one, what we've kind of done with the pilot is to promote confidence to clinicians. And also integrate them into existing pathways that were already available and kind of being used for the 12 lead. We've taken the opportunity to roll it out in line with the physical health check devices to technology solutions to do the checks for SMI patients. So just a little bit around how we've done it is we've got a network forum that we have on a monthly basis around for physical health checks, and we've got a bit of a dialogue that we use for the ECGs to turn around and share some best practice, how deployment's gone with each system. What we kind of did was quite early was take kind of a collaborative approach to deploy the ECGs, because we wanted to avoid each clinical service doing it individually and kind of do it more on a shared level, and use things like the DPIA, a standard operating procedure, as a single overall document. But at the same time, we recognise that each system has their own committee sign off, a template that they might already have within their organisation. So it's kind of given them an overall kind of a version that they can then tailor for their own service. we've had a kind of a mature system over up north, the TCS and Ware Valley's NHS Foundation Trust. So we've used them as kind of how they did it, what was their best practice, how did they engage with their clinicians to get to use the ECGs, and kind of sharing a lot of their best practice, which again gives some confidence around how to use the 6 lead versus the 12 lead. Because what we did here is the 12 lead was working well. A few issues in terms of the patient interaction versus what the 6 lead can do, but overall there was quite of a challenge around trying to get it deployed. So another part of what we've done with the forum and kind of offline in terms of collating feedback from systems is what has gone well for them, what challenges have they faced, and we've recognised the themes around it and then try to kind of give some responses back to share experiences and overcome some of those barriers. Next slide, please. So some of the benefits that we've heard from clinicians and staff that have been using the devices, which has been more around from the HCAs, is that previously primary care staff reported a lack of availability in their surgeries in terms of the 12 lead ECGs. So the 6 lead ones are a lot easier and quicker to use and can kind of give them a recognition of if they need to do more with the patient, it gives them a kind of a baseline. The new machines, they kind of sit on the patient's, place on the patient's knee or the ankle, so it preserves their dignity. And where patients are kind of felt a little bit uncomfortable around exposing themselves, they felt a lot more comfortable with the knee and the ankle use. The results are printed very easily on through the actual ECG itself, and also by doing a 6 lead ECG, it also prevents having to get more appointments and getting the patient to come in for a second appointment or do a further referral. But obviously, if it's needed because it's been picked up on the 6th lead, then that's the pathway that the patient does have to follow. They are a lot more portable and compatible, so you can kind of take them out and about, and HCAs, so you've been using them over with patients' homes and care homes. So on the preference of carrying a smaller machine than a bigger machine has been a preference. Next slide, please. Okay, so this is a little bit around kind of the on the ground, how it's been going and some of the issues and challenges we've heard from systems. So a lot of it has been around the resources and in staff capacity, but the kind of way we've kind of managed this to share with systems is try to use what you've already got within your 12 lead and get your staff trained up to use the 6 lead ECG instead of trying to get more staff to come in as in recruitment. But also there's been about the interpretation service, like not all staff can read the results. So and Lexi will go a little bit more into this, is how that interpretation has worked and how they've used junior doctors to work with the HCAs and the psychiatrists to sign off the ECGs. There's been a lot of queries around the variation between the 12 and the 6 lead. Obviously, the 12 lead gives you a slightly more of a deeper ECG result than a 6 lead, but the 6 lead gives you is kind of designed to be quick and fast. So it gives you a result in 1 minute, and like I said, it kind of sits on the patient's ankle or knee. But the advice we've kind of given to our systems is use both models and perhaps use the 6 one as a first one, and then if a further it is required, then use the 12 lead. Another issue that we faced was not all HCAs had mobile phones, so they had their own personal phones that they used. But obviously, because with the 6 lead there is the PID information, so a lot of our systems have had to secure mobile phones through their procurement to allow patients staff to have their own mobile phones, but also then protected through IT governance to make sure the data is secured safely. IG, so a lot of systems didn't really have a DPIA, and with the pressures in the pandemic and then the Omicron surge, it wasn't something that systems could just start developing, and this is where we wanted to take on a more of a collaborative approach for them all. So we've got a high-level DPI that is available for systems to tailor and sign it off with their own protocol. A high-level SOP is currently being designed, and that should be available kind of over the next few weeks. In terms of training staff, there's a lot of training material on how to use ECGs, whether it's videos, and there's a lot of material on a page that the NHS Ts had set up, which is accessible as well. For reporting, we did a bit of a monthly catch up with system leads to kind of receive soft intelligence around how is it going, what are the issues, how well are they being performed and used, and number of patients that are having ECGs, but also around how they're piloting it, just to gather some of that information, which again we share quite nationally through other leads that are doing kind of equivalent role, but also through the network forum that we have monthly in the Midlands. A key challenge that's kind of been hit over the last year, well, the last couple of years, but even more so recently, was due to the change in the guidance around the vaccination programme. It's about how we can continue with doing ECGs and NSMI work without pausing it, and the importance of it. So we've worked with our systems to kind of keep that momentum going. Okay, next slide, please. This is over to Lexi just to talk through about the local primary care approach that I took in Coventry and Warwickshire.
Thanks, Harinder. So when the, oh sorry, I've got a bit of an echo. When the offer for the 6 lead ECG machines came up, we were delighted in Coventry and Warwickshire. So our clinicians had highlighted previously that ECGs are essential due to the impact on heart rhythm by some of the antipsychotic medications. Historically, we had few portable machines, but they're really key when delivering health checks remotely, particularly to populations that are harder to reach. So with severe mental illness patients, we're working to address barrier to access, and we understand that for some, a 12-lead ECG creates anxiety, and it means that someone else needs to touch them, they need to remove their clothes, and 6-lead ECGs negate these fears, as Harinder mentioned. You know, being placed on the ankle or knee allows the patient in some instances to do it themselves as well. So we received our ECG devices in July, and it has been a bit of a long road into getting them operational. Our main concerns were about who would sort of read and interpret abnormal results, conscious that any abnormal results detected would require swift attention. So we took some time, held discussions in order to consider the best pathway for patients. Our chief nurse at Coventry and Rugby GP Alliance, who employ our HCA cohort that deliver the annual health checks, agreed to review any abnormal results via secure email and password protected document. We then had another slight hurdle regarding how to use the devices due to PID being stored on the Cardia mobile app. So we had to find funding to purchase mobile phones for our HCAs that are utilising the machines. We had that approved, purchased mobiles. Whilst that was going on, we created a SOP for the ECGs, which was reviewed by board members and approved. We then hit a further hurdle with the mobile phones being set up with our secondary care trust IT system, and they had multiple restrictions on them. That took some time to unblock, but we did use that time to undertake training with staff members on using the devices in the meantime. So we're finally able to implement the devices on the 24th of January 22 by 5 staff members, with each having undertaken an ECG on a patient during their SMI physical health check since then. None of those have yet required any onward referral due to their results, which is positive. It's important to note as well that where our secondary care teams have been using these machines, we're aware that there have been a number of occasions where the readout has suggested an immediate problem, and people have been sent on to A&E following that being reviewed by a consultant within the team. So I think that's probably all from us, but happy to take Q&As if we have time, or later in the event if not.
Super. Thank you so much. Thank you for that. If our panelists could all just come back on screen, we've just got a bit of time for questions. So we've Dr. Qureshi, Roma, Alison and Harinder and Lexi, you just stay on a moment. Is everyone there? Put your cameras on. Thanks. So I've just been monitoring the chat. There's been quite a lot of questions and comments, and maybe if you're able to stay on and just kind of answer some of the specific questions, that would be really helpful. I know some of you have been doing that already, but I'll just go to Dr. Qureshi and Roma. In terms of your deployment into care homes linked with PC, where did you start? Do you go with the willing? Do you do a small bit in each PCN and allow them to sort of go on to deploy it themselves with a bit of support? Just what's your advice and model of where to start with care homes?
Dr. Crasher, you answer.
Just trying to unmute, sorry. Right. What we did actually, Laura, was it was initially a PCN-based project, and this was a part of their PCN development plan. But it very quickly became a Warwickshire North-wide project with all the PCNs then coming on board. So it started at the PCN as an expression of interest. And then we went into the other areas such as Coventry, Rugby and South Warwickshire, presented the concept and asked for expression of interest. So it initially started as an expression of interest in the PCN that was initially doing the investment, and were willing to trial the concept and share the learning. But as soon as, even before they went live fully, the other PCNs had already started to engage. So it started with 1 and expanded to 5. And then, you know, the word went out and we did presentations and expression of interest. So that's mainly how we started the rollout. But within the PCN, we actually did some intelligence before we started the care home work. If they had an outbreak, if they had issues, we spoke to care homes and picked the ones which were ready to go ahead and trial. And then it needed chopping and changing a little bit because of the COVID outbreak. So it was quite a lot of adaptations and flexibility even during the rollout. So that's how we rolled it out in the area.
Super, thank you. That's really helpful. Alison, your presentation really told us about that patient perspective, and 96% of patients, you know, satisfied with that service and care. I'm interested to know, because you say, you know, patients did prefer the digital first approach. Do you think they would have preferred that approach had it not been a pandemic and a national lockdown? Just interested to see if you think that was a catalyst for patients being comfortable with digital first, or, you know, just get your views of that.
I think possibly it, you know, had a bit of weight behind it really with the pandemic, but I mean, we've been using digital monitoring before the pandemic, and patients have always seen, I think it's quite, it's, like I said before, it's convenient for a lot of patients. They don't have to have the visits all the time. Some patients really, you know, do want to have that face-to-face contact. Some patients are quite happy to have it, you know, be monitored remotely. So I think there's always been that that interest from patients to do both really. But I think the pandemic just kind of, you know, exacerbated that really. So but yeah, both really.
And just a question, how did you gather that patient feedback? Did you do it through the tool or other means?
Yes, so there's a tool that we used, and friends and family questionnaires that were sent to the patients, and they asked them the questions and whether they'd, you know, recommend the service and how they found the service, that kind of thing. So yeah.
Super, thank you. Just to Harinder and Lexi, physical health checks for people with severe mental illness is quite a complicated pathway, isn't it? Because you've got primary care involved, secondary mental health, and how do you go about finding the right patient cohort in amongst all of that? And you said that HCAs do the test. How do they route the data back into whomever the clinical service lead is, be it community mental health or primary care, or is that a work in progress?
So I can probably take that one from a local perspective, Harinder, if that's helpful. So it is very complex area of work, Laura. So we are lucky that we've, over the last couple of years, implemented a model which works between primary and secondary care. We have a team of HCAs that are employed by our local GP alliance, and they work to a lead nurse. So any abnormal results are reported through to the team nurse, and they also have paramedic teams that can review those if needed. In terms of the sort of data flows, the HCAs, there's a contract in place between the secondary care and primary care providers, so that they are able to read into both EMIS and care notes and able to update accordingly across both systems, because obviously there's huge interoperability issues that have been present, and that's kind of our workaround at the moment whilst we're waiting for an integrated care record.
Super, thank you. And then just a final question for all of you, really, and we'll go kind of round the group in turn. What do you really want to happen next with your programmes? What's your kind of your next stage, big idea and ambition? If we go to Dr. Qureshi and Roma first.
Well, we're looking to scale up across the whole of Coventry and Warwickshire. So we're already working across Warwickshire into both South Warwickshire and Rugby. We're looking to do some further integration into Accurex, so that the clinical hubs known as the ICC and ISPAs can use some nudges, etc. We're currently deploying out across long-term conditions, and we've got 148 patients in Warwickshire North who are using Docabo in a box for their long-term condition monitoring. We're just about to deploy that out into heart failure. And once we've done the testing there, we lift and shift across the rest of Coventry and Warwickshire. We're already working on the end of life, and we're doing those question sets with the hospices. So we're looking at now getting the integration into the hospices so that they can receive the alerts as well, and then their community palliative care teams can manage the interventions if they are required. We're also now looking to work at doing the acute trusts and starting to set up the virtual ward rounds within the acute trust. So we'll have like Swift at home, George Eliot at home, and UHCW at home. I was interested to hear this morning about the sort of like from Manchester, the way that they've badged their programme, and I think that's something that we can take from this meeting and look to do something very similar. So we're working at the moment to start doing virtual ward rounds for the acute trusts. That's where we are.
Brilliant. Sounds like you're leaving no stone unturned. Alison, what's the next big thing for you?
So I mentioned it briefly in my presentation, but we're developing a COPD virtual ward for supported discharge. So patients that have been acutely unwell in hospital. We're going to be working with the hospital team to get patients out at home. We will then monitor them daily for 14 days. More of like an enhanced respiratory service, but do that remotely, and obviously visit patients if we need to. So that's in the very near future. And also we're hoping to develop a asthma virtual ward as well, and so that's also in the pipeline at the moment. But yes, we've got the COVID virtual ward that we're running at the minute as well, and the pulmonary rehab digital pathway as well that we're running. So yeah, we're expanding the service.
Fantastic. And last but not least, Harinder and Lexi. So I guess you're kind of looking to bed in and develop this further, notwithstanding the fact that this is a very complicated pathway.
I think it's complex, but also it's a case of we're in a space of doing more tech-enabled solutions to kind of help patients get the best results quick and easy and get them onto the right pathway for treatment, but also prevention. I think that's quite a key area with ECGs as well as with the physical health check. There's nothing worse than receiving technology and it just sits in somebody's, with the pandemic, we've heard it's been sitting in people's garages and all sorts of very odd and strange stories. But it's about us working collaboratively, and where it's already happening nationally is kind of using that best practice to get the clinical side of the pathways with clinicians working with the digital solutions. So I think that's the kind of the big space. But it's definitely the whole innovative area to get people with the right results and get them onto the right pathway quickly.
Fantastic. Well, thank you all so much. Can't really wait to hear what's next with all of your projects, and I think you will be able to find more details about some of these projects on the Future NHS site. But thank you all so much.